This video is going to go over chest tubes. What is a chest tube? It is essentially a device used to drain air or fluid from the pleural space in order to restore the lungs to normal function. What type of patient might have a chest tube? Anytime there's a surgery that opens up the chest wall, so anytime there's a surgery such as a thoracotomy, the patient will have a chest tube placed, because when the surgeon cuts into that chest wall, air enters the space, which leads to a loss in negative pressure. And if you recall from A&P, the lungs work on a negative pressure system. So if there's not enough negative pressure, then the lung can collapse. Surgery such as a thoracotomy can also lead to blood residing in the pleural space as well. We want to get whether it's air or blood or fluid out of that pleural space so that the lungs can work properly. Any introduction of air into the pleural space would be indicative of a chest tube being placed. A pneumothorax can occur spontaneously or can occur as a result of trauma, such as a penetrating trauma like a bullet wound. Blood in the pleural space would be a reason that a patient would have a chest tube placed. That's commonly called a hemothorax, hemo meaning blood. Common causes for hemothorax include trauma, cancer, tuberculosis, or even some sorts of thoracic or cardiovascular surgeries. And then finally, so not just blood or hemothorax, but if there's any sort of infection or purulent fluid in the pleural space, such as empyema, or with any pleural effusions, a chest tube may be placed to drain those fluids. So again, chest tube is basically draining air or fluid from the pleural space so that the lung can function properly. And you can see in this diagram, depending on where the chest tube is placed, will tell us what is being removed from the patient. So if we're worried about a pneumothorax or air being in the pleural space, the chest tube will be placed higher near the apex of the lung. If we're worried about fluid or blood, the chest tube would be placed lower towards the base of the lung. And to get those straight, I think about if I had a bottle of water that was half drank, the fluid's always going to be at the top, even if I turn the bottle upside down, right? The fluid will go to the top and the liquid would settle at the bottom. So here's an example of a chest tube drainage system, and basically the tube is attached to the patient. This tube's attached to the patient, and it would pull off into the drainage collection area any blood, fluid, or pull through any air that might be in the pleural space that we want to get out by using the chest tube. The chest tube has 3 chambers. The first chamber is the drainage chamber. And this chamber is what collects the fluid being pulled, is where the fluid being pulled from the pleural cavity is collected, whether it's blood, serosanguinous fluid, or purulent fluid. Any fluid being pulled off the patient would collect in this drainage collection chamber. This fluid must be measured hourly during the first 24 hours after the chest tube drainage, the chest tube has been placed. And it's important to note that the fluid in this chamber must never fill up to the point that it comes in contact with any. So it must never fill up to the point that it comes in contact with any tube. So if these were to fill up and then it's blocking off this tube, that would be a bad thing. If that fluid were to come into contact with that tube, drainage would stop, and that could lead to a tension pneumothorax. Chamber 2 is the water seal that prevents air from re-entering the patient's pleural space. As the trapped air leaves the pleural space, it passes through chamber 1, right? So air comes down, passes through chamber 1 and through chamber 2 through the water seal. There should always be at least 2 centimeters of water in the water seal that will prevent any air from returning back into the patient, right? So this is a one-way system. We're pulling away, nothing's ever going back to the patient. So the water seal is a seal that prevents air from re-entering the patient. You will see water bubble in this water seal. If your patient has a pneumothorax and it's just inserted and that air is being pulled off, you will see the water seal bubble. But bubbling, when bubbling is seen when it's first inserted. Again, that could be for the pneumothorax. Other times it may be seen is when the patient exhales, coughs, or sneezes. When air in the pleural space has been removed, the bubbling will stop. A blocked or kinked chest tube can also cause bubbling to stop. Excessive bubbling, so this is the one here, big NCLEX type question you're going to see. Excessive continuous bubbling in the water seal chamber, the second chamber, may indicate an air leak. So excessive bubbling, continuous bubbling in that water seal chamber would be indicative of an air leak, and we'd have to figure out where the leak was. Tidling is something that you'll see in that second water seal chamber also, and that is normal. That would be that water moving up and down just a little bit along with the patient's inhalation and exhalation. If there's an absence of this fluctuation, the tidling, the water moving up and down a little bit, that may mean that the lung has fully re-expanded or that there's an obstruction of the chest tube. And finally, the third chamber is the suction control chamber, and that third chamber does just that. It controls the amount of suction being applied to that chest tube. There's different types of drainage systems. You might have a wet drainage system or a dry drainage system. The picture here shows a wet drainage system because we actually use liquid to help control the amount of suction. With wet suction, the fluid level in the chamber, and chamber 3 is prescribed by the primary healthcare provider and is usually 20 centimeters of water. So when a monitor will add as much water, sterile water has been ordered by the physician, and that's something you need to monitor every shift, is to see where the level of water in both the suction control chamber and the water seal chamber are. And if they've gone down, you want to add some to make sure that they're at the right level. In terms of the suction control, this third chamber, basically we would then attach the drainage system to suction and turn it on until we see a continuous bubbling in this suction control chamber. So continuous bubbling in the suction control chamber is something that we want to see. That means that the device is on, that it's working, that it's applying suction. There are other types that have dry suction, and basically the provider will prescribe the suction level to be dialed into a device, so they don't use liquid to obtain that suction. And it's important to note the amount of suction in the system is determined not by the wall unit, what you're dialed up to, but by the amount of fluid indicated on the manufacturer's guide or by the physician as to how high you should fill that. In terms of management of chest tube drainage systems, at the bedside, you're always going to want to make sure you have sterile gauze, padded clamps, and sterile water, and we'll get into the reasons why you might use those in a minute. And as a nurse, our job is to ensure the sterility and patency of the drainage system. So we want to be checking it hourly. We want to tape any tubing junctions to prevent accidental disconnections and to make sure that the occlusive dressing is intact. We want to make sure there's no kinks or large loops in the tubing that provide a dependent area for fluid to accumulate. We want to avoid stripping the tubing, and if we notice a clot, you could do a gentle milking to try and move the clot down, where you would squeeze and then release, squeeze and release. But you wouldn't want to do a vigorous stripping or pulling on the tube because that can create negative pressure and could actually damage lung tissue. In terms of assessing our patient's respiratory status, we want to assess that. We want to look at pulse ox. We want to watch our ABGs if they're being drawn. We want to listen to lung sounds, assess for any difficulty breathing, monitor the alignment of the trachea to make sure that's midline. We want to look at the tube insertion site, look for the skin around there, and maybe palpate and check for any crackling that could be indicative of subcutaneous emphysema. Look for bleeding. Respiratory rate, if I didn't say that one. We'll want to monitor the drainage that we're collecting, and if we see that we're collecting more than 70 milliliters per hour, we'd want to notify the physician. So we definitely want to be monitoring that frequently when it's first inserted. After the first 24 hours, Usually that drainage slows down and you can assess it around every 8 hours or so. So you've come in, you've assessed your patient's respiratory status, you've assessed the system itself, the tubing, junctions, you've assessed the drainage collection. Next, again, we want to make sure that we're regularly checking the water seal chamber and the suction control chamber. Again, the water chamber seal should not have continuous bubbling. That would be indicative of an air leak. And the suction control chamber should have continuous bubbling. If the water seal chamber has continuous bubbling, if the water chamber has continuous, or the water seal chamber has continuous bubbling with a provider's prescription, you can use the padded clamps to briefly clamp off the tubing that's connected to the patient to try and locate where the leak is occurring at. So you would start closest to the patient's body and apply the clamp. If the bubbling stops, the air leak may be at the chest tube insertion site or within the chest and would require physician intervention. If the bubbling does not stop, then you could move the padded clamp down closer and closer to the drainage system until you can locate what area might have the leak. It's important to know that you'd only want to use a clamp with the provider's order, and then it's important to release the clamp as soon as possible. So as soon as we assess that either yes, we see a leak, or no, it continues, or we're moving along checking, we would want to release that clamp and never leave the chest tube clamped off. So noticing any of those eyelets on the chest tubing would be a reason to immediately notify the physician or rapid response team. Other sort of emergency notify the physician now type of things we'll notice on the patient could include tracheal deviation, sudden onset or increased intensity of dyspnea, oxygen saturation of less than 90%, drainage greater than 70 milliliters per hour. 70 is your big number there. If the chest tube falls out of the patient, what we'd want to do in that situation is to cover the area with the sterile gauze that we have at the bedside. Immediately cover it with the sterile gauze. If the chest tube stays in the patient but disconnects from the drainage system, what we'd want to do is to put the end of the tube into a container of sterile water and keep that below the level of the patient's chest until we can get that hooked back up to another drainage system. And then also if drainage in the tube stops, especially in that first 24 hours, so all your patient's putting forth a lot of fluid and all of a sudden it stops, that would be a big red flag that something has clogged up. After we check the tubing for any kinks or dependent loops, we'd want to then notify the physician.